My name is Kevin Raphael. I work with Assist International, and we are glad today to welcome you to our 6th session of the Oxygen Therapy and Critical Care, the case-based series. You are all warmly welcomed, and I would like to remind you that this session is brought to you in collaboration with Assist International, Stanford Division of Global Medicine, and University of New Mexico Health Institute, together with Project Echo. A few housekeeping items before we begin our session. Remember that we will be using the chat function for question and answers at the bottom of the screen. Please send all the questions through the chat box, and also feel free to introduce yourself. If you have any IT issues and you need assistance, you can send a message through the chat. Also remember that our session is being recorded and your attendance is consent to be recorded. If you have any audio problem, if you can't hear the music, you can try one of these tips. On your phone, you can tap on the speakers at the top left, or you can try to use headphones, or you can try to log out and then log back in. After those items, I would like to welcome Dr. Ananya to introduce himself and our session today together with the other panelists. Dr. Ananya, please welcome.
Thank you, Kevin, for a nice introduction. As you said, today will be the part 6 of our oxygen therapy and critical care case-based series. And today we're going to have panelists with us, Dr. Hussein Idris, who's an anesthesiologist and critical care specialist, currently working at Gondar University, and is a sole physician, anesthesiologist, and critical care specialist in Gondar and handling ICUs and OR. We are hoping as well Dr. Brahana to join us in a while. Is also our panelist today, anesthesiologist and critical care specialist working in Menelik II Hospital, Addis Ababa, which is an affiliate of Addis Ababa University, Tukur Ambassa Specialized Hospital. Thank you, panelists, for joining us, and we'll be continuing the session. Yeah, so our today's session will be a basic ICU care considerations, continuation of our case-based discussion before, and then considering also COVID-19 infection as a center. And today our discussion will be focusing on a case of Mr. T, who is a 46-year-old man who presents with hypoxemia and respiratory distress. And considering this case, okay, I think screen sharing is disabled again. Sorry for technology problem.
Yes, sir.
Yeah, now we are able to resume it. Okay. Yeah, so as we usually say, we have a practice change objective. So after completion of this session, we want to see a change in our practice, and these practice change objectives are going to be identifying the minimum standard of intensive care unit, which is in terms of healthcare provider, type of monitors needed, and specialized equipment needed. And also we want to know able to list the most common indication for ICU admission, and will be able to understand and prevent the most common complications that occur in ICU patients. And we will review, develop and implement ICU care bundles for our ICU. So this is our practice change objective. And we'll start with, giving more on the case, broader information about Mr. T. He's a 46-year-old male with history of obesity and type 2 diabetes mellitus, who presents to the emergency department after 3 days of shortness of breath, cough, and fever. Physical exam, He appears well, his breathing is not labored, and he's speaking in full sentences. Past surgical history, he has laparoscopic cholecystectomy at 2012, and he has no smoking or drinking or use of illicit drugs. And he lives with multiple family members and works as at an office as a water engineer. And his vital sign is heart rate 98, blood pressure 127 by 63, respiratory rate is 30, temperature is 36.5 degrees Celsius, and the saturation of oxygen is 87%. Now at the emergency, he is placed on an anaerobizer mask at 10 liters per minute. And with this intervention, his saturation improves to 92%. And the emergency room physician now places a call to the on-call ICU physician for that means admission to ICU and intervention. So at this point, now what do you think is an ICU? What's an ICU for you? All of you have come across the word ICU. So can you take just a minute, as usual, to write what you mean or the definition of ICU in the chat box? Yeah, what is an ICU? I know most of you have come across this word or you are using it every day, of course. So anyone so far? I'm not seeing anyone writing on the chats. Probably you are trying to write a very long definition, so you can use even words which can explain what an ICU is. Yeah, I think we have one response. It says a place where patients requiring organ support would be managed. Excellent. So it contains a component of, this place, one thing. The other thing is a place where we apply organ support. So very good. Another trial, it's a place of intensive follow-up organ support and monitoring with much human resource. So this definition even include more components now regarding the human resource, the monitoring requirement, how intensive is going to be there, and the presence of follow-up is included. Thank you. It's a specialized ward packed with specially trained professionals who takes care of critically ill patients. So you tell us about the professionals and the severity of the illness of our patients. Yeah, also a place where were equipped with monitorings and patients closely followed. So component of monitoring and the need for equipment is addressed. A specialized treatment, okay, specialized treatment for acutely unwell or critically ill patients. So even it tells us that the kind of treatment we're delivering is somewhat special. And about the equipment, dealing with life-threatening medical condition, very good. And the level of care is going to be a high level of care as well, trained individual. It's a part of curative, okay? Curative care is going to be delivered in ICU, good. And simply intensive care unit, okay? ICU stands for intensive care unit. So I agree with all the definitions, okay? So you can see the picture now full of graphs, and it is composed of, different words, and all these words will help to define an ICU, okay? As all of you were trying to define an ICU, you defined it in terms of a place, okay? A specialized place in the hospital, okay? You try to define it with a kind of equipments that needs to be available and the kind of service, specialized service to be delivered, and what you are going to deliver also to the patient is an organ support, and the kind of patients who are going to be treated in ICU, the patient with organ failure or life-threatening conditions. And, the type of human resource that needs to be available, the specially trained individuals. So all are aggregated here, okay? If you see life-threatening is a big portion in the definition of ICU, organ support, monitoring, okay, but patient management, okay, here it is vital, so it's vital signs are frequently seen, and here you can see as a physiologic, so where you can manage physiologic derangements, okay, pathologies, and so on. So you have defined, critical care well in that it's a specialized unit where critically ill patients with life-threatening conditions are being managed with incorporation of, organ support and using the special equipment for monitoring, and with the presence of, specially trained nurses, physicians. So there are different societies like, World Society of Critical Care Medicine, and Australia and New Zealand, European Society of Critical Care Medicine. They have their own definition, but the definition mainly involves these components. And if only 3 words are to be taken from these graphs, then support, organ support, life-threatening, and monitoring would really define ICU. So the other thing in the definition of ICU we have to consider is time. So critical care is a moment in time, and it is a delivery of care that is time critical, okay? So in a timely fashion, delivering care for sick patients is also what we may say critical care, okay? It's a saying by a Mexican anesthesiologist, okay, Rubio, which is critical care is a moment in time. It's delivery of care that is time critical, okay? In our last session, we discussed about the concept of time critical. So critical care is really time sensitive. So if we say so about ICU here, then let's go to, a minimum standard, okay? What minimum standard needs to be fulfilled so that our ICU can fulfill the definition of an ICU. So this is going to be our one of practice change items, okay? Just before, exercising with a case here, a question here, I would like to also read for you the World Federation of Intensive and Critical Care Society or Federation definition of ICU. So an ICU is an organized system for the provision of care to critically ill patients that provides intensive and specialized medical and nursing care, an enhanced capacity for monitoring and multiple modalities of physiologic organ support to sustain life during a period of life-threatening organ system insufficiencies. This definition more or less incorporates all the components in defining ICU. And from here, you can pick, what are the minimum requirement standards to say that the service we are giving or the place or the care we are giving is really an ICU care, okay? So now let's exercise. Okay, which of the following are standard components of an intensive care unit? So we have 6 choices. It's a poll kind of quiz. So please try to answer your question on the chat. So continuous monitoring, specialty trained health care providers, system for delivery of time critical care, specialized patient care equipment, rapid access to diagnostic and therapeutics, or all of the above. So which one of the following are standard components of an intensive care unit? Yeah, I'm seeing so many people saying all 6, okay? That means 100% of participants are saying 6, all of the above. And that is the correct answer, okay? So all of these are standard component of intensive care unit, as there is a need for continuous monitoring. The care providers needs to have special training, and the service needs to be, time-based, time-critical care, and there needs to be, rapid access to diagnostic and therapeutic. So all are components. Thank you for the nice participation. Okay. Now, looking into the minimum standard, okay, the first ones will be healthcare providers. Okay. So what is the minimum healthcare provider needed? And what type of healthcare providers are also needed in ICU will be addressed. Okay. So in order to address that, we'll update the case of Mr. T further. Okay. As I was trying to tell you previously, he was put on, Mr. T was put on 10 liters per minute of oxygen by non-breather mask. But despite that, let's say Mr. T's saturation decreased to 89%. And his respiratory rate increased to 32. Let's say he's only speaking 2 to 3 words at a time, okay? Now, do you think that Mr. T need ICU now? If you think, why? If not, why not, okay? So can you just take a minute to write your answer on a chat box? So looking into the case given, what do you think? Does Mr. T need an ICU admission? Why or why not? So, yeah, the answer was already given previously, actually. Yes, he does. Okay, most of you are saying now, yes, he does. Because he needed mechanical ventilation. Okay, he is already on impending respiratory failure. His respiratory force is increasing. Yes, he needs ICU, even he may need mechanical ventilator. Okay, for respiratory system support. So patient is showing sign of respiratory failure, which can only be followed and treated in the ICU. So he need an ICU. Very good. He is in respiratory failure, right? So most of you are saying that he is in respiratory failure or impending respiratory failure and he need an ICU admission. So let me invite here Dr. Hussein, is our panelist today. So do you agree with most of our participants that Mr. T needs an ICU admission, right?
Yeah, thank you all the participants. As you most of you said, this patient actually needs an ICU admission because we are giving 10 liters of oxygen, which is basically the maximum possible oxygen that can be administered by this the non-reusing face mask. So the patient further needs continuous monitoring of his saturation and, if possible, continuous monitoring of his arterial oxygen tension measurement and carbon dioxide measurement is possible need of mechanical ventilatory support. This patient needs to be admitted to ICU and further cases like including the high flow oxygen therapy or maybe a trial of non-invasive like CPAP and BiPAP trial can be considered. And finally, if the patient is going to deteriorate or the patient is not responding well, then the intubation and mechanical ventilation may be warrant for this patient. So this patient needs to be admitted to the ICU.
Yeah. So this patient definitely needs now an ICU admission. Further escalation of care, as Dr. Hussein has said, with further oxygen administration, high flow or non-invasive CPAP or any sort of oxygen administration with escalated of care and closer monitoring. As you see, this patient has already shown a path of deterioration. So further deterioration means this patient needs a management even with invasive mechanical ventilation. And as many of you are saying, he's showing a sign of respiratory failure. So definitely, as we all agree, this patient needs an ICU admission. So if this patient is admitted to ICU, then he will be, followed by some professionals. So which of the following listed below from 1 to 6 do you think are essential staff for an ICU? So, these are ICU trained nurses, ICU trained physician, respiratory therapist, physiotherapist, pharmacists, cleaners, janitors, or all of the above are important. Now I'm seeing all. Okay, all. Yeah, most of you are saying all of the above. So yes, because I know most of you have experience working in ICU. You might have seen as well an ICU. So an ICU, all these staffs are quite essential. It's not only trained nurses and physicians who are part of management of the patient. But if you, for example, consider pharmacies, then they are very much important in avoiding, the drug errors or drug dosage error or drug interaction. They can dispense drugs, and they will give you a lot of support there. Okay, respiratory therapists and physiotherapists are quite needed. If patient on mechanical ventilator, there won't be success unless and otherwise you manage secretions. Okay, you manage the chest wall muscles to exercise and work, and you manage the ventilators, okay, closely according to the patient's lung condition and so on. So respiratory therapists, physiotherapists are also very important. Cleaners play a major role there in prevention of infection transmission, and also keeping the area we are working clean and neat. So without cleaners, we cannot, provide critical care. Janitors are the ones who really control the flow of, the traffic of the ICU. And it's one of a major challenge in ICU where attendants and other, even the public, without knowing, it's thinking that's a pass to exit the hospital, they tend to enter ICU and so on. So janitors really are very important. So when this team are working together, then our ICU care will be effective. Otherwise, when we lack one or more of these team members, then our ICU care will be compromised. Dr. Hussein, as you are from Gondar, and probably at your ICU, do you have all this staff in your ICU? How do you see the importance of each staff?
Yeah, as most of our participants says, and as we have discussed, ICU is basically a multidisciplinary care facility whereby a lot of multidisciplinary team is required to improve the outcome of our patients. So among this, it's clear that specifically ICU trained physicians, which may include direct intensivists, anesthesiologists, pulmonary and critical care specialists, depending on the country's law, is actually necessary. Plus, specifically ICU trained nurses are very important. And also, all that's mentioned in the text is required. But the problem in our setup in the lower and middle income countries is that most of the ICUs located in these areas are not well staffed properly. For example, in my setup in our ICU, I'm the only physician anesthesiologist actually. Plus, most of our ICU nurses are not trained specifically for the ICU. They are just rotated from other wards. They are general nurses. Plus, there is no respiratory therapist in our area, so the anesthesiologist also handles these respiratory therapy decisions. Plus, the physiotherapists. Actually, there are physiotherapists in our campus, but it is by an on-call basis. So there is a great gap in availability of such professionals in our setup. The pharmacists, of course, there are clinical pharmacists. Still, their involvement is very scarce in the ICU clinical setup. Plus, but the cleaners, the janitors, well, they are involved in daily activities, but due to poor educational background in the health, especially in the health field, and they are poorly trained in how to prevent the transmission of infectious diseases and so on. Due to that, probably their effect might be hindered, but they are very important staffs. I agree. Yeah, so in the future, such staffs should be, team of ICU care should be established in each ICU center with appropriate pathway of training and also professional development activities. I say that.
Yeah, thank you, Dr. Hussein. This is a reality in most of ICUs in our setup throughout Ethiopia. So most of the time, as you said, respiratory therapists are almost non-existent, but replacing their work, with physician, and then we have some physiotherapists trying to do, just physiotherapy and so on. Otherwise, as you said, also pharmacists are not usually joining grounds or working in the ICU. So by definition, we are really short-staffed in most of our ICUs in Ethiopia. So this has to be incorporated as a minimum standard to be fulfilled. So all of us should take, an assignment to improve our setup, incorporating this important, vital staff components in the management of our ICU. So everybody has important roles. That's a message. So I mean, something we're trying to say. So which of the above providers could improve the care of Mr. T? And how and why? Okay. So we were kind of discussing that as well. But if participants can write something, one or two things, then we can pass to the next item. So which of the previous providers listed are important in improving care of Mr. T? And how and why? So there is also a good document here in a learning resource center about minimum standards for intensive care unit. It is shared to everyone on the chat box. If you go to your chat box, you can see the standards being shared. The link for a minimum standard is shared, so it's good if you go through it and read it later. So anyone can try this. Yes, thank you from Adisu. All are important, but this patient ICU trained physician is especially important for escalating oxygen therapy and management decision. So thank you, Adisu. So as Adisu said, all are quite important. So all can add up for improvement of care of Mr. T. But specifically going to physicians, the physician is the one who's managing, ordering oxygen or other drugs. And he said, his physician is important. So what I will say at this as this interface will be, all are, equally important. So teamwork. So all members are equally important. Lack of one or two or more of this team can lead to compromisation of this Mr. T's treatment. So all are important and all have their own role. That's why they are needed. Okay, physician is the one who's managing the patient, and the nurses are the ones giving nursing care, and the janitors are the one who are taking care of flow and traffic and security issues. So everyone is quite vital and important. Thank you, Adisu, for what you said, and you can proceed to The next practice change action item is about the monitoring. Okay, what monitoring or minimum monitoring is needed in intensive care units. So let's update the case. Let's say now Mr. T is transferred from the emergency department to ICU as we all agreed, and after evaluation by the ICU physician, of course, and he's placed in isolation room with negative pressure as a person under investigation for COVID-19. Then he continues oxygen therapy with non-rebreather mask, but the flow has been increased from 10 liters to 15 liters per minute. Now, admitted in ICU, which monitor should be placed on this patient? So what monitors would you be placing on this patient if this patient is admitted to your ICU? Take a minute to respond this on the chat box. Okay, we have one response. Yeah, BP, ECG, pulse oximetry in the tidal CO2 monitoring. Okay, great. A pulse oximeter, and continuous ECG monitoring and blood pressure. Okay, not only just ECG or blood pressure monitoring, but it needs to be continuous. Okay, that's what I'm feeling from this comment. Okay, temperature monitoring as well. Yeah, most of the time, in our ICUs, we forget to monitor temperature, but monitors are available with a continuous temperature monitoring availability with auxiliary probe, as well as oropharyngeal, nasopharyngeal probe. So yes, ECG, blood pressure, SpO2 in the tidal CO2 temperature monitoring. Yes, I think exactly. That's what we need to place the patient on. Okay, the patient already having signs, symptoms of respiratory failure, high oxygen demand, admitted to ICU. So these patients require continuous ECG monitoring, blood pressure monitoring, saturation, continuously being monitored, temperature, and then setups available in the tidal CO2 to measure, patients' minute ventilation is quite important. So, okay, that's great, but here a point of discussion will be, are these monitors available throughout the country? Maybe Dr. Hussein, you can tell us your institution, but in our institution we may not have, in the tidal CO2 monitoring, and continuous blood pressure monitoring is also limited by a lack of this transducer and modules, so we only do for a specific group of population. So what's your experience in Gondar, maybe?
In Gondar also we have non-invasive blood pressure monitor, the pulse oximetry, like peripheral saturation measurement, continuous ECG monitoring, and temperature probe are available. Otherwise, we don't have like the the arterial blood pressure monitoring and the carbon dioxide or the capnograph monitoring are not available in our ICU. That's
So,
because that's because our machine, there is no the cable in the gas collector for the carbon dioxide monitor doesn't fit with the screen of the monitor. That's why we can't do that.
Yeah, that's a limitation. Otherwise, if this monitoring modalities were there, we could have improve the quality of care in our ICUs. So in general, for ICU, we have a minimum standard of monitoring, and it's international as well as local standards. Before maybe going into that standard, can we just respond to the next question? Like, which of the following is not a patient monitoring requirement found in most of ICUs? Okay. So is it ECG, pulse oximeter, arterial blood pressure, transcranial Doppler, respiratory rate, or none of the above? So there are monitoring requirements. It's international, local, worldwide. So in most of these standard requirements, which one is not incorporated? Okay, from the one listed from 1 to 6. Yeah, so I can see 4. So 4 means transcranial Doppler. Okay. Again, 4. Yeah, also 4. Transcranial Doppler. Yeah, I think it's a straightforward question. As most of you have said, transcranial Doppler is not something as a routine requirement or as a minimum standard for patients in most ICUs. In a specialized ICU like neurocritical care patients, transcranial Doppler may be needed. But in most of ICUs, this is a bit sophisticated and the need is much less lower, so it's not included. Okay. So there should be, I'm trying to open it. Yes. So here we can see, an article regarding, the minimum monitoring requirements, including, admission, some complication. Okay. So if you go to, the Learning Resource Center and click on a part which says click on the question of blue background, then you can find, an associated article or material which can support you to answer the question. So most of the ICUs and ECG, pulse oximeter, arterial blood pressure, respiratory rate, temperature, and in the tidal CO2 is a requirement. But transcranial Doppler, you will not find it as a requirement, but it also has its own important role in some patient groups. So let's update the case now. Let's say after admission to ICU and put on 15 liters of oxygen, heart rate is now 102, blood pressure is 117 by 52, respiratory rate is 32, temperature is 7.5 degrees Celsius, saturation is 91%. Okay. So in addition to patient monitors, these are standard patient monitor. what other type of monitors are needed in the ICU? Now the patient is admitted, getting, escalation of oxygen support, his saturation, his vitals are like this. Now you are monitoring a patient with ECG, continuous blood pressure, the temperature monitor, saturation. Is there anything else you need to monitor in ICU? Or what other types of monitors are needed in ICU? So that means other than, standard patient monitors, multi-parameter monitors you have, is there any other type of monitors or monitoring, in the ICU? So now we're having, ABG, so arterial blood gas analysis needs to be seen, glucometer, urinary catheter, glucometer, capnograph, I agree with most of you. Input output, ABG, RBs, fluid balance, electrolytes, even laboratories like organ function test. So all of what you are mentioning is about monitoring the patient using different modalities. One is a monitor, the other one is using ABG, glucometer, or even laboratory. Then clinical monitoring, as you said, urine output, fluid balance, and patients, response clinically can be done. Anything else other than the things wrote in the chat box?
Probably, someone said mentation. Yeah, mentation can be indirectly monitored by the ICP monitoring, the continuous EEG monitoring, and also GCS also monitoring maybe included.
Yeah, so the best monitor in the ICU is clinician itself, be it a nurse or be it a physician, and it's the best monitor, so you can see clinical changes of the patient. Of course, it needs experience, but despite what the monitors are saying, the physician or nurse can know if the patient is deteriorating or improving with some clinical signs. Then what you have said, the patient monitors, including the monitor on our wall or other monitoring modalities. It could be ABGs, the like that you have mentioned are also a part of monitor. But apart from this monitoring, there is also a monitoring of equipment. So most of our equipment we are using, we need to monitor them. Unless and otherwise we monitor them, then there could be an error, or they may not be delivering what we expect the equipments to deliver to the patients. Let's say mechanical ventilator, then that needs to be monitored by ourselves. We have oxygen cylinders, and if we are not monitoring, the oxygen may get finished, and the patient may go into hypoxemia. So we are monitoring. We are monitoring our suction machine or any kind of equipment we are having. We need to monitor, and we look for alarms. When we monitor, also we look for alarms. So we monitor our alarms. So in some sophisticated setups, like a negative pressure system will be monitored, or a pipeline, a gas system will be monitored. So whenever there is a failure in oxygen delivery through a pipe system, then there will be an alarm, and that alarm will make you, to act in order to avoid hypoxemia to patients. And a negative pressure system as well in COVID era, where you have a negative pressure system in your setup, and when this is lost, then there needs to be an alarm which alerts you to act accordingly. Okay. Then there is also monitoring for patient transport. So it's different when you transport a patient or when the patient is in the ICU bed. It's quite different. So portable monitoring tools like pulse oximetry and other tools needs to be available while transporting patients. So monitoring is not just only those vital sign monitoring, but you monitor everything about the patient clinically, as most of you said, but also monitoring of equipments is quite important. But a bedside nurse or physician is the most important monitor in the ICU. So maybe one of the challenges in our ICU is, at some time you'll find an ICU with no medical personnel. Okay, when you visit your ICU at duty hours, lunchtime, or late night, you'll find a patient lying alone with just a monitor and no nurse by the side or no physician by the side. And we are losing, a most important monitor at that point in time. I'm not sure if this is the case in Gondar as well, Dr. Hussein, but this is something we are being challenged.
Yeah, it is a similar scenario in our setup also. There are different unwitnessed and monitored incidents while in ICU or during transportation, even from the imaging suites from ward to the ICU. A lot of complications have been recorded and reported in our setup.
Yeah, that's one of the challenges. That should, this session is also to highlight such issues, and we can improve them after this discussion. So we have to put our effort in improving these things at our ICU. So probably if you have looked into the minimum standards for ICU, what is the recommended maximum nurse to patient ratio for critically ill patients in the ICU? Is it 1:4, 1:5, 1:3, or 1:2? That is a nurse to patient ratio. So as a minimum requirement, what is the maximum number of patients a nurse has to take care or has to look after in ICU? So yeah, most says 1:2, 1:2. There is even 1:1, even though there is no any choice. Yeah, that's highly desirable. 1:1 is already 1:2. Yeah. Yeah, most says 1:2. So here I can show you, a table of a minimum requirement, for ICU. This should be, the maximum should be 1:2, one nurse for 2 patients, nothing more than that. 1:1 is even more preferred. Patients are critically ill, sick. They need invasive monitoring. They need frequent positioning, blood sampling, and so on. So you see, ICU care needs to be 1:1 or 1:2. Sometimes 2 nurses for 1. For those with having an infusion, okay, too much high reliance with infusion, administration of drugs, and so on. But in intermediate medical units, up to 1 to 3 or telemetry or level 1, 1 to 4. Okay, in ward, maybe international recommendation is 1 to 5. Okay, so as you can see, as the level of care increases, like from ward to ICUs, and the patient nurse to patient ratio needs to be as well improved. And as most of you said, 1 to 2 or 1 to 1 is a requirement. So we have to work towards that. Yes, majority of ICUs, maybe in public, maybe tertiary hospitals and so on, I think they can fulfill this criteria. I'm not sure what the situation is at Gondar, maybe Dr. Hussein.
Yeah, the problem with this guideline is basically it has, especially in developing countries like ours, the flow of this guideline is that this guideline considers one thing: the ICU is equipped with a multidisciplinary team, as we discussed previously, including the respiratory therapist, the physiotherapist, and so on. But the actual scenario in our condition is we don't have respiratory therapists, we don't have physiotherapists, so the nurses are actually like replacing the responsibilities like handled by such professionals. One thing. The second one is this guideline also assumes that the nurses should be specifically trained for ICU. But as I've said, most of the ICU nurses are not specifically trained for ICU. So due to that, there is always a conflict in doing this ratio 1 to 2, 1 to 1. For example, in our setup, we have like 5 beds for surgical ICU, for which we have 4 nurses. But sometimes even the team leaders might decrease the number of nurses to 3, 4, 5 patients. So this causes a conflict. So I think this guideline needs to be evaluated, needs to be, the workload for ICU nurses should be reassessed, and this guideline should be considered, I say. Otherwise, for the moment, we have 5 beds, 3 or 5 nurses, depending on the case.
Yeah. I think you can find, this requirement, a minimum requirement in the Learning Resource Center, and you can use that resource, to convince people around. It really matters. It really affects patient care. We have, enough nurses these days, so it should be possible to have 1 to 2 nurse to patient ratio. That's the minimum requirement, So the next action item will be, specialized equipment needed in the intensive care unit. So maybe if we look to this question, which of the following specialized equipment is least likely needed in the care of Mr. T? So can you identify which one is the least likely needed in the care of Mr. T? It's airway equipment, mechanical ventilator, manual ventilation mask and bag, external ventricular drain, or suction apparatus. Yeah, 4, 4, 4, 4. Yes. Yeah. Definitely. This is a patient having, primarily of respiratory pathology and having also respiratory failure now. So we all need, this suction apparatus, then manual ventilation mask and bag, even airway equipment, because we are going to intubate these patients, and mechanical ventilator is important. External ventricular drain is something we place for a patient with head injury or intracranial pressure issues. So at least the other specialized equipments are quite needed. So what other specialized equipments common and helpful in the care of ICU patients? So other than, mentioned now in the list above, are there any specialized equipment which are common and helpful in the care of ICU patients? So yeah, I'm seeing CVP, ultrasound, AED, defibrillators, okay, perfusers, defibrillator. So this was a document I was telling you about, the minimum standard for intensive care units. Okay, it has got, general requirement for intensive care unit, staffing, medical staff, nursing staff, other educational, what system or operational mechanism there is. Okay, the structure of an ICU by itself, it's a design, okay, with a working area, medical offices, everything, also equipment, okay, what basic equipment is and specialized equipment is needed, and monitoring, okay, different monitoring also defines level of care. So as if you go and read through this document from College of Intensive Care Medicine, and you can find all the minimum requirements. And coming back to our discussion point here, specialized equipments are the ones you list, these are, even portable X-ray, EEG machine, okay, CVP monitor, ICP monitor, ABGs, defibrillator, perfusers are the one we are considering them as, specialized equipment, okay. So some centers may have also, dialysis machine is a part of, an ICU with a specialized equipment. So all these are widely available in most Western setups, and maybe lacking in our, but it's quite helpful. So we have to think of, having our ICUs being equipped with such specialized equipment. Now, let's proceed to, indications for ICU admission. Okay, we have tried to cover, the minimum standards in terms of personnel, equipment, monitoring, and specialized equipment. Now, what are indications for ICU admission? So can you list? Okay, it's one of our question here. So very good. Something we haven't mentioned, but bronchoscope is also quite important, in diagnosing issues with airway, okay, or in the tracheal tube and the lower down, so the tracheobronchial tree. So yeah, in general, organ failure, right? So column is telling us that impending respiratory failure, hemodynamic instability, and so on. Yeah, neurosurgical patients. For patients who are having, any organ failure and who needed organ support are indicated for an ICU admission. And for patients who need, frequent monitoring with a high risk of, deterioration. And one of the examples could be, post-neurosurgical patients having neurosurgery of specific type, actually, may need to be admitted to look for, any further deterioration and prevention as well. Yeah, severe COVID-19 hypoxemia, GCS less than 8. Yeah. So Can you say something here, Dr. Hussein, in short, regarding indication for ICU admission?
Okay, so indications for ICU admission actually may vary from setup to setup, depending on one, the patient condition, the patient needs. Does the patient need ICU admission actually? Will the patient be benefited if the patient is admitted to ICU? Second, that the requirements that the patient needs are available in ICU in terms of professional plus equipment wise, as they're available in the ICU. Plus, if the number of beds available enough to handle all the patients that need ICU admission at the time should be considered for ICU admission for a given setup. So to solve this problem, a lot of guidelines have been used and have been developed through in different ICU setups. And it's also recommended that every ICU has its own protocol depending on the local conditions. So, for example, the criteria could be one thing, based on the priority. Based on the priority that will the patient need emergent life-threatening care in the ICU, plus is the patient's likelihood of survival good or not. You should compare this to admit the patient. And also if the patient's clinical condition can be managed outside of the ICU with the close observation, like in the intermediate wards with high dependency unit and so on, also may decide that. The second one is based on the diagnosis. Specific type of diagnosis may be needed to be admitted to ICU. For example, you may say severe ARDS, patients with neurologic disease that affect the diaphragm, which may affect their breathing, like GBS and so on, may be needed. Third, cardiovascular abnormalities, including malignant arrhythmias that result in hemodynamic instability with invasive monitoring and invasive treatment needed. And the other one is when the patient has refractory or septic shock that may need long-term vasopressor therapy and so on. So based on such diagnosis, we may admit to ICU as well. And the other possible techniques that we can use to decide whether to admit or not is that the objective criteria model, that is based on the patient's vital signs, based on the patient's imaging findings or the patient's investigation results. Based on this, we can decide whether the patient needs to be admitted or not. For example, if the patient vital sign like BP is less than 90, if the pulse rate is more than 140, if the patient has bilateral chest abnormalities with X-ray or CT scan with desaturation and so on, such features, such objective measurements can help us decide whether the patient needs to be admitted or not. So in general, as we said, things that we should consider are first, the patient's need, actual need. Second, the availability of the need in the ICU should determine the ICU admission criteria, and each ICU needs its own admission criteria. So everyone should facilitate the establishment of this guideline in your setup.
Yeah, thank you, Hussein, for the comprehensive description of the admission criteria. And as you said, admission to ICU may differ from setup to setup, but in Ethiopia we use common admission criteria. We have a nationally developed guideline for critical care admission based on priority model, because ICU, the space is limited and we want to preserve resources. So based on a priority model, those with life-threatening condition and highly likelihood of survival will be admitted to get support. And most of these patients have, one or more organ failure or impending failure. And the objective and diagnostic method of admission to ICU is also important. And you use each component together so that you can decide. And as Dr. Hussein said, at each institution, it's good to have institutional guideline as well. But commonest cause of admissions are what our participants are also presenting, respiratory failure, hemodynamic failure, neurology, all sorts of organ failure, tetanus, and so on, are the ones which are commonest indications for our ICU. If we say so regarding, admission, indication for admission, then after admission to ICU, a complication can occur, and this complication needs to be prevented and needs to be known as well. So in order to exercise that, let me update the case of Mr. T. Let's say now Mr. T is beginning to look obviously fatigued. He is less awake, he has labored breathing, and his color is looking more dusky or cyanotic. He is asking for help to breathe. Vital now heart rate is 100 to BP 97/51, respiratory rate 37, temperature 37.5 degrees Celsius, his saturation dropped to 87%. Now what clinical steps should be taken to care for Mr. T? Maybe let me give you 1 minute to say something on the chat box. So now his clinical scenario is like this at this point after admission to ICU, and what clinical steps should be taken care of. So now Mr. T in the ICU, is fatigued, labored breathing, cyanotic. He's asking for help to breathe. Saturation is also dropping. So I think, yeah, the Jenny Melissa said ventilatory support. Stefanos put on fluid, give oxygen support and give fluids. Okay. So approach him as ABC of life. First is airways and go to breathing, then ventilation, and go to circulation. So is the deteriorating patient. So standard approach of ABCDE. Okay, that's great, good. Yeah, I think it's obvious, right? This patient is now developing a full-blown respiratory failure, and he needs to be on organ support. So you have to make yourself ready for intubating this patient, arrange drugs, medication, airway, equipment. Make sure that he has a good IV line. Maybe the blood pressure, as you can see, 97/51 during intubation. This may further go down, so you want to have a good IV line, ready with vasopressor. Start maybe giving a fluid bolus. Try to increase saturation with ambubag and oxygen, tight fitting mask. He's less awake, so maybe non-invasive ventilation may not be an issue. So some people may tell you, okay, increase oxygen support with high flow nasal cannula or non-invasively. But it's an area could be a debate, but this patient definitely is cyanotic, less awake, and is having a respiratory failure and almost fatigued. So readiness for mechanical ventilation, intubation, optimization of the condition for intubation is something which we need to go along with, okay? So let's say now, let's update the case as the ICU team attempts to place Mr. T on oxygen therapy by high flow nasal cannula. He loses consciousness. After successful intubation, he is placed on mechanical ventilator. He is now hemodynamically stable and under sedation. Next, the ICU team decided to place a urinary catheter and an internal jugular central line for increased venous access to draw blood for lab and monitoring of central venous pressure. So, can you list some common complications that occur with ICU care? Okay, as we were updating the case, the ICU team just tried first with high flow nasal cannula, but he loses consciousness when they are trying to put him on high flow nasal cannula. So they have to go to intubation and put on mechanical ventilator, Ideally, after patients put on ventilation in mechanical ventilations, and most require sedation, so the patient put on sedation and hemodynamically stable. But despite that, you need to have adequate venous access. So it's a standard to put internal jugular or any central line for a mechanically ventilated patient. And urinary catheter needs to be placed to monitor input output. And central line catheter is important, not only just having a vascular access, but also to monitor the central venous pressure and also to draw labs when it is needed. Okay, to draw lab blood, you don't need to poke in different peripheral lines once you put central. So after you put all these things and the patient start on ventilatory support, what common complications can occur in ICU? So can you name some and chat it on the chat box? Yeah, so let's see the chats. Ventilator-associated pneumonia, arrhythmia, infection, UTI, acute kidney injury, air embolism, pneumothorax, VAP. Okay. Oxygen toxicity, barotrauma, bedsore, DVT, almost all the list of complications. Right, Dr. Hussein, you agree with our participants? Most are mentioned, right?
Yes, most of the complication as mentioned. So ICU it's the center for treating most critical patients. It's also associated with most common and most serious complications too, starting from the decision to admission, which includes the patient may be anxious, the patient may be agitated, or the patient may even frustrate while decided to admit to the ICU. And after admission, the patient may have a pain due to a lot of interventions or positionings and a lot of instruments applied to the patient. And in addition, the patient may develop infection. The infection could be due to the indwelling invasive procedures, including intubation, which resulted into the ventilator-associated pneumonia. Then the UTI, especially catheter, urinary catheter-associated urinary tract infection is common, plus central line, if the patient is on central line, then central venous central line associated bloodstream infection is common as well. And if the patient is also on invasive arterial blood monitor, infection plus dislodgement and bleeding also can happen in such patients. And sepsis is common as well in ICU, as ICU-acquired sepsis and septic shock can happen. And the other one is, as you said, DVT due to the disease process, due to their bedriddeness and so on. DVT and PTE can happen. The other one is also organ failure, multi-organ failure that may involve the cardiovascular, arrhythmia, and shock, plus renal failure, liver failure. A lot of organs may be involved. The other one is bed sore, stress ulcer, and also medication. The use of medication. Since we use a lot of combination of medications, there may be medication error plus the medication. Interaction. Medication interaction also can result in serious adverse effect. Plus malnutrition also common in ICU, especially in our setup, whereby the nutritional treatment or patients who are already malnourished are admitted to ICU, and our care for nutrition is poor in our ICU. And the other one is also after discharge, the patient may have a lot of physical, mental, and cognitive problems, which we call it the PICS, the post-intensive care syndrome, that involves neuromuscular weakness, sleep disturbance, anxiety, depression, and cognitive impairment, like lack of memory and performing complex issues may be impaired. So such a lot of vast complications may be happen. So that's why we need a comprehensive multidisciplinary approach should be considered, including the intensivists, the nurses that we mentioned previously, plus the psychiatrists, the physical therapists, the psychologists, the social interventionists also should involve in the care of ICU patients even after.
Yeah, thank you, Dr. Hussein. Thank you. Almost, the picture, if you see the picture here, it really explains what common complications that can occur, and most of are mentioned by Dr. Hussein. Maybe, patients can get, delirious. There is a complication associated with oversedation. When you oversedate patients, then this further may develop into a PICS syndrome. And, antibiotics resistance is also something which can occur with irrational use of antibiotics. So all these are a list of common complications, and that can really be prevented, okay? In order to prevent them, the strategy we are using is, having a care bundle. So using a care bundles, we can prevent different complications we mentioned, okay? So the next section will be, dealing with the care bundles. We'll review some of them, and we'll, encourage you to develop or to implement the ICU care bundles for your practice, for your ICU. So in interest of time, maybe I'll leave this exercise point here and maybe see what is in our resource center. I'll go fast through the document in the resource center. So understanding the care bundles, you can find, this article in our Learning Resource Center, and you can read it later. But, care bundle is in a set of interventions you are going to use in order to improve patient outcome. And the types of bundles available could be, ventilator bundle, okay, to prevent ventilator-associated pneumonia. It involves, 4 components like administering the vent prophylaxis, administering medication to prevent gastric ulceration, elevating the head of the bed between 30 and 45, and providing a daily sedation vaccination or holding a sedative for the purpose of assessing whether the patient can breathe independently of the ventilator. So this can increase your success of weaning a patient from a mechanical ventilator. So reduce the duration the patients are on a mechanical ventilator and helps in preventing ventilator-associated pneumonia. Okay, so by using this bundle of head elevation, medication for gastric ulceration, venous, the deep vein prophylaxis, and daily sedative vacation, you can prevent ventilator-associated pneumonia. Okay. What else is another bundle, So we have a bundle for severe sepsis, as Dr. Hussein was telling us. Sepsis could be one of the complications that can occur in ICU. So there is a resuscitation bundle for severe sepsis. So you obtain blood culture, okay, when you suspect someone is having the sepsis, then the resuscitation bundle guides is you obtain blood culture, administer broad spectrum antibiotics, measure serum lactate level or arterial blood gases with correction of metabolic acidosis, okay, based on your finding, and inserting urinary catheter to monitor fluid balance, treating hypotension with fluid challenges, and if not responding with vasopressor. So this is something you have to do when you diagnose sepsis, and within 6 hours of recognition, this is a resuscitation bundle. Whereas, when it's sepsis management bundle and the resuscitation bundle is a bit different. So when sepsis management bundle consists of interventions that must be performed within 24 hours of diagnosis. And this include, administration of low-dose steroid for septic shock in accordance with standardized ICU policy, administering recombinant human activated protein C, okay, if available, maintaining a glucose control, lower limit of normal, but below 180, okay, and maintaining a median inspiratory blood pressure of less than 30 centimeters for mechanically ventilated patients is, the sepsis management bundle, okay, within 24 hours. For a resuscitation bundle is something to be done in 6 hours. So if you comply with, these care bundles, then you can prevent complications, what was mentioned also by our participants, barotraumas, boliotraumas, and mechanical ventilator traumas can be really reduced if you are using, plateau pressure less than 30 centimeters of water. And, other complications really can be improved using this bundle. So we have a lot of, bundles. We have, so maybe let me go back to here to see some of them presented in pictures. Central line associated bloodstream infection is one of the complications commonly occurring after, central line is being inserted. And in order to, minimize this infection, then if you follow these steps, then you can greatly reduce, such devastating infection, like properly wash your hand beforehand and wear, sterile glove, hat, mask, and gown. So complete asepsis technique is recommended. Then you need to completely cover a patient, okay, with your drape, and clean the sites with chlorhexidine antiseptic solution. So chlorhexidine solution is found to be very effective in preventing catheter-associated infection. Then remove catheter when they are no longer needed. So sometimes we put a catheter and we forget to remove it as early as possible. So whenever they are no longer needed, the catheter needs to be removed, and the daily monitoring of the catheter sites and having a transparent tape is very important here, and as much as possible avoiding femoral lines, okay, and using internal jugular or something higher. Subclavian is much more preferred, as infection is much higher when you are near to the perineum. So these are, part of bundles. And if you follow these care bundles, then you can really minimize, risk of catheter-associated infection. So the other commonest complication is, catheter-associated urinary tract infection. There is also bundle here, cavity bundle. So catheter removal is all about, removing catheter as early as possible whenever the need is over, and aseptic insertion during insertion time have to follow clear aseptic technique, okay? And we have to regularly assess, okay, the urine the urine color, is it clean, is it turbid, and regularly it should be assessed. And training for catheter care, okay? Sometimes there is this kind of practice that they clean the catheter and the urethral area with antiseptic solution and so on. So these kind of things are not generally recommended, but routine cleaning hygiene needs to be there. So there needs to be a training for catheter care. So you have to give this to your nurses or physicians who are following the patient. And also incontinence care planning. So everyone who has incontinence need not to be having the catheter inserted. So, using this care bundle, we can really avoid catheter-associated infection. And the sepsis and septic shock is something we have seen also on the document, the first hour bundle for initial resuscitation is what we have said previously, but at least a measurement of lactate, obtaining blood culture, okay, and administration of fluid and vasopressor as early as possible to keep a mean arterial pressure greater than 65 millimeter of mercury, and fluid, as I said, broad spectrum antibiotics is one of the most important in the initial resuscitation hour. Okay, so for 24 hours, are the ones we mentioned previously, including, keeping the plateau pressure less than 30 centimeters of water. So these are in general some of the common bundles we are using, and we have to be familiarized with them, adopt them, or develop or customize to our setup. And by using them, we can really reduce complication in ICU. So Dr. Hussein was mentioning about peaks. Let's see a short video here about peaks.
Many people now survive critical illness. Healthcare professionals used to assume that patients who survived critical illnesses returned to how they were before. However, stories of patients with profound struggles after being hospitalized emerged, such as James, Maria's, and Ping's stories. James was a businessman. He had sepsis from a severe bout of pneumonia and needed life support for 10 days. For months after his illness, he was forgetful, had difficulty concentrating, and frequently lost his train of thought. James was asked to copy this drawing, and he drew this. Maria was a professor. She had severe influenza. Her kidneys and lungs failed, meaning that she needed dialysis and a breathing machine for 2 weeks. After her hospitalization, Maria had profound weakness. She had to learn to walk again at a rehabilitation center. Ping was in 4th grade when he was hit by a car. After being in the intensive care unit, or ICU, he went to a rehabilitation hospital. Ping talked little at rehab, but learned how to use his arms and legs again. He had a hard time reconnecting with his friends. During the past 20 years, research has confirmed that these types of stories happen more often than not. In 2010, the Society of Critical Care Medicine, or SCCM, gathered together experts involved in the care of ICU survivors. The group named the combination of problems common to survivors of critical illness post-intensive care syndrome, or PICS. PICS includes new challenges to the brain, body, and emotions, and is seen in more than half of critical illness survivors. Children surviving critical illness often have similar problems, such as delayed developmental milestones, learning problems, and sadness. Families and friends are also affected. For example, James' persistent problems led to his wife giving up her job to be his caregiver. Researchers are working to prevent and treat PICS. SCCM believes that ICU survivors can share their stories to help each other, which is why its Thrive initiative is building a network of face-to-face groups for critical illness survivors. In 2015, 6 Thrive sites were launched. In 2016 and 2017, even more will join. If critical illness has touched you or a loved one, please join us. Let's create a better recovery together. More resources about PICS and the Thrive initiative can be found here.
Yeah, it was a nice video about PICS, and I think all of us have an understanding now. So, in order to avoid PICS as a serious problem, then we have to use, ICU liberation bundle, and this are from A to F, and A stands for assess, prevent, and manage pain. We need to assess and prevent and manage pain, and managing pain will help you, in avoiding such complication like PICS. And so every day, at least post spontaneous awakening trial and post breathing trial should be done. If you are not doing this, you go to over sedation, and you don't know if the patient has a good response to your ventilation, and the patient may stay on ventilator for long. And also, this sedative agents are known to be associated with, post ICU myopathies, neuropathies. So, in order to avoid such complication, daily you have to have spontaneous awakening trials. That means you hold your sedative drug daily, and also encourage having a spontaneous breathing trial to see if the patient has a good breathing effort. And you need to also choose between your analgesic and sedative agents according to availability, and but also according to user clinical, clinical effects. And we have to define the depth of sedation as well. So that determine the dosage, the frequency when you are giving your medication. Then D stands for delirium. So every time you have to assess for the presence of delirium. You have a CAM ICU or other tools available. So using the tool assess, then prevent and manage. Okay, if there is delirium, you manage it. If there is no delirium during your assessment, then you can prevent it with using different strategies. Like your ICU needs to be calmer with no noise. The patient needs to be as much as possible comfortable, and if possible, the family visit is something also very important, without affecting the ICU traffic. And by incorporating such methods and with a careful use of analgesic, sedative, and adequate management of pain, then delirium can be really prevented. And early mobility and exercise is also very important in avoiding peaks. As you know, as you are using your muscle, you can avoid disuse, atrophy, and your joints can work well, and the neuromuscular interaction will be very good, and your GI motility, your GI function can be returned quite fast. So early mobility and exercise is important. And as I said, family engagement and empowerment in the management of our ICU patients quite important in avoiding peaks. So this is one of the care bundle you may want to incorporate in your day-to-day practice, known as ICU liberation bundle from A to F, okay, mainly related with pain or sedative agents, okay, delirium, mobilization, okay, exercise, okay, bedside exercise, physiotherapy, and family engagement. This is what we have for today, basic ICU considerations regarding the minimum requirement indication for ICU admission and the common complications and how to prevent common complication in our ICU. These were our key topics review. I'll read through them so that you can get the most out of it. So an ICU is a separate hospital unit staffed by a specially trained physician and nurses who work closely with other specialized staff to care for patients. ICU patients need intense monitoring and support for failing organ system. ICU requires specialized continuous patient monitoring system. ICU requires specialized life supporting equipment. Indication for ICU admission differ depending upon resource availability, local risk factor, and the health of the local community. Critically ill patients in the ICU can suffer several complications that must be prevented and monitored, and care bundles can decrease ICU complications, and post-ICU syndrome can have significant long-term impact on patients who have recovered from critical illness. This, you have seen it, also with a video. And also it affects patient family, so engaging family earlier is also important. And it should follow PAD's guideline for ICU liberation. So there needs to be a guideline for ICU liberation and also use of the bundle, okay? So these are our key points, and the rest is about, the actions you have to take, in order to accomplish, what we have said today. At least if you establish a critical committee, if you don't have anyone, that really helps, and nominate appropriate leader. Then advocate for additional equipment according to the minimum equipment requirement, and advocate for additional staff, trained staff according to the minimum requirements. Advocate for additional education, so those staff needs to be trained. So advocate for policy and system to deliver time critical care and prevent the most common complications that occur in critical care patients with implementation of ICU care bundle for your ICU. If you do that, then we can accomplish, a betterment of our ICU care. Thank you for your time and your patience to attend today's session. So I would like to thank all the participants and our panelist, Dr. Hussein, who has been very active and giving what he knows for us, and all the supporting staff, Kevin, who opened our session, and all the Ico staff and others who helped in organizing this today's session. So thank you, everyone. And if Dr. Hussein, if you have something to say, then I will leave the floor for you, and Kevin will close the session. Thank you.
Yeah, I want to say thank you, everyone involving in today's session. Thank you.
Yeah, maybe, one of our panelists didn't show up today. Dr. Brahana, he has got some problem, and he was not able to join us. But despite that, we were able to do the session with Dr. Hussein as a panelist, as a single panelist. So thank you, Dr. Hussein. I think Kevin, you can close the session.
Thank you so much, Dr. Ananya. Thank you for the very good and very elaborate session. We've for sure learned a lot. We have reached the end of our session today, and thanks to all the participants for giving your time until the end of the session. We apologize for finishing a little bit out of time, but we will try our best for the next session to keep in time. So you can visit the Learning Resource Center for presentation slides and recording, also for many additional resources, quizzes, case exercises, and videos. And that is the link to the Learning Resource Center. Also, we'll share the link after this session by email. You can join the community Telegram group by scanning this QR code here, or you can send a message to assist through the number shown on the screen there. We would like to thank you all, and if you have any question, you can send them through this email, echo@assistinternational.org. And please remember to join us for session number 7 next month, which is going to be held on Tuesday of November the 30th. We're going to be discussing on defined acute respiratory distress syndrome. So you are all warmly welcomed. And until then, we wish you a good time and all the best. Thank you and see you then. Bye.
Thank you. Have a nice day or night.
Thank you, Dr. Anand. Echo India team, I think we can close the session now.
Sure, thank you.